I've been asked to talk about the challenges facing the National Health Service, change in the National Health Service, obviously particularly following the completion of the legislative phases on the Health and Social Care Act as it now is. I don't propose to talk very much about the Act for reasons that will become, I hope, clear in the course of what I do say. But just for the record, let me be clear, I voted for the Act as it went through the House of Commons. I am supportive of the changes that are being made in the form of introduction of greater clinical engagement in commissioning, in the form of strengthened links between the National Health Service and local government. I also think the changes in public health offer the opportunity for significant benefit. But although I voted for the Act, I regard virtually all the claims that have been made for it on both sides of the argument, both those who are advocates of the Act as a major leap forward in terms of the management of the health service, and indeed those who oppose it on the grounds that it's the end of the health service in its familiar form. The arguments on both sides, I think, have been grotesquely overstated. I think that the changes, when we come back to look at this Act in the context of history, the changes that it introduces will be seen to have been relatively modest, although in my view, they're changes that should be welcomed. And the reason I say that I think they're relatively modest is that I think it's the third time in 22 years that we've legislated, broadly speaking, the same set of ideas for how the health service should be managed. I was first a health minister in the summer of 1990, 22 years ago, when Ken Clarke was Secretary of State for Health. And at that stage, we introduced what we called purchaser-provider, the concept that people who hold the budgets and hold responsibility for shaping healthcare in a particular community should be separate from those who provide the care. That was the fundamental idea in the 1990 Act. It was the idea that Alan Milburn re-legislated as a member of the Blair government in the early part of the last decade, and it's the fundamental idea behind this Act as well. So it's the third time we've legislated the same basic set of ideas. I don't believe that it moves, I don't believe it changes the geography as fundamentally as either the proponents or the opponents of the Act have claimed. Much, much more importantly, in my view, the fact that the Act is now on the statute book allows us to address what I regard as over a different order of magnitude in terms of their importance to the health service, and those are the issues that we need to address in order to achieve change, not of the management structure of the health service, but of the way care is delivered. The experience of the delivery of care by people who work in the health and social care system, and most important of all, the experience of the care that is actually delivered to the people who rely on the health and care system. And I want to talk this morning primarily not about the Act, but about the fundamental purpose of the Act. And because a key mistake, I think, in the political arguments, again, on both sides around the Act, has been that they've all been about form rather than about function. And I'm old-fashioned enough to think that form should follow function. You shouldn't seek to dictate function through form. What's important in health and care delivery is understanding what it is you're trying to do, what is the nature of the challenge facing the system, and then organize your structures in order to deliver the objectives that we all have to have for the system. So let me go there, because that's the key issue facing all of us who care about the future shape of the health and care system. There are, it seems to me, two elements to the challenge facing those of us who care, those of us who need to think about where the system needs to go next. Two elements of challenge. Both of them brought together in the phrase that the select committee that I chair uses to encapsulate these challenges, the Nicholson challenge. The Nicholson challenge is firstly an economic challenge and secondly a quality challenge. And the core argument I want to make to you this morning is that those two challenges can only be addressed if they're seen as different elements of the same management challenge that faces every one of us. But they're different elements and each of them needs to be understood. Take the economic element of the challenge first. It's the old management truth, isn't it? You manage that you can measure. What gets measured gets managed. I'll get there in the end. The key economic challenge in the health service is relatively easy to articulate. It is that in this country and in every other developed country, demand on the health and care system grows by, roughly speaking, 4% per annum. You can argue it varies a bit from year to year, but if you take a trend rate and deal in whole numbers, it's relatively soon after breakfast, whole numbers are good enough. 4% per annum, year in, year out, is the level, it's the rate at which demand upon this system has grown since 1948 in this country and is growing in other comparable countries. So there's no reason to assume that there's going to be any change in the trend rate of growth for the services that the health and care system delivers. We should assume they will continue to grow by 4% per annum. During the life of our healthcare system since 1948, that growth of demand running at 4% per annum has been met by 3% real growth of resources and 1% growth of efficiency. 3 plus 1 equals 4. The core economic challenge, summarised in the phrase the Nicholson challenge, is that for the lifetime of this Parliament, and indeed now we're being told, I think unavoidably, truthfully, this will be a challenge that will progress on into the next Parliament as well. For the lifetime of this Parliament and into the next Parliament, that 4% trend growth rate in demand has to be met not by 3% growth in real resources and 1% growth in efficiency. It has to be met with 0% in round numbers growth in real resources. And you don't need to be a mathematician to work out the only way you balance that equation is 4% growth in productivity. So the core economic challenge facing the health and care system is that a system that has a trend growth rate over 60 years of 1% productivity gain a year has suddenly to multiply that by a factor of 4 and achieve, and this is what I'm describing, of course, is what's, I think, best known as the NHS 20 billion. I don't find that a very helpful description of the challenge because it leaves open the question, what is the 20 billion? If you describe it as cuts, it's not entirely accurate because the money's still going to be spent. It's going to be spent treating more patients. So the challenge is how you deliver 4% efficiency gain 4 years running and then go on doing it after the end of this Parliament out of a system that has a trend growth rate of productivity over 60 years of 1% per annum. That's the economic challenge facing the system. Let me leave that as item number 1. How do we achieve 4% productivity gain 4 years running and plan to carry that process forward into the next Parliament? And then move to the second element of the challenge. Because this isn't just about making the sums add up. It's also a system, as we know, where there are already significant quality problems. In particular, there are quality problems that arise because the system, as it's experienced by the core user group of the health and care system, is fragmented, isn't able to deliver care in a way that is seamless and matches their quality aspirations, our quality aspirations, for the service that needs to be delivered. And let's be clear who we're talking about. I describe them as the core group of service users. Very often in SW1, when people talk about health and care, they think the typical patient of the National Health Service is somebody speaking broadly like them. Somebody who turns up occasionally in a television studio, but otherwise is to be found around Westminster. Normally healthy, goes in to see a doctor occasionally, has an episode of care, and walks out normally healthy again. That's thought to be, by the policy-making community, or at least the policy commentariat, the typical patient of the National Health Service. Actually, of course, we know that patient, although they're numerically very large, in terms of the workload on the health and care system, they're a very small share of what the system needs, of the care that the system needs to deliver. The core patient, the core user of these services, is somebody with multiple conditions from which they are not going to walk out cured, and who are long-term patients and users of the system. We need to be able to deliver much, much more integrated care, much more focused care, a care that's much better focused on their desire to lead a life that is never going to be 100% healthy, if that concept exists, 100% healthy again. But they want to be supported, they need to be supported, we want to support them to get as much as possible out of the longer life that modern healthcare has allowed them to live. So we have two challenges. We have an economic challenge. How do we deliver 4% efficiency gain 4 years running? And we have a quality challenge. How do we take services that have grown up around traditional silos, traditional institutions delivering care for a different generation with a different set of health needs? How do we take those institutions to deliver care that is better focused and better meets the quality aspirations of the different needs, underlined again, the different needs of today's and tomorrow's users of these services? So those are the two challenges. And I said at the beginning, I hope we can, I'm clear in my own mind that they have to be seen as two sides, two elements of the same key challenge facing the health and care system, which is how does the system change as we look forward? How do we introduce a dynamism into the system to change, to meet the economic challenge, while at the same time meeting this quality challenge of the changing, driven by the changing demands of our core group of patients? And they're two sides of the same thing for one very simple reason. The only way, there is no, put it the other way, put it as a negative. There is no way of meeting the efficiency challenge that I described, 4% efficiency gain 4 years running and then going on beyond that. There's no way of doing that just by buying a bit cleverer. If you sharpen up your purchasing, run down a bit of administration cost, that doesn't come close to meeting the economic challenge facing the system. The challenge facing the system is a classic change management, a change management project. The only way you meet that kind of efficiency gain out of one of the largest organizations in the world is to rethink the way we deliver care and to rethink it in the context of the changed demands placed on the system, which I described. No longer people who have an episode of care that needs to be treated and they walk out healthy. We need to focus on the needs with long-term conditions, people who need more integrated community-based services. We need to focus on intervening earlier in order to avoid the unnecessary acute case, in order to support people living into the community rather than picking up the pieces when their condition deteriorates and they end up, the acute patient, in the acute hospital. And it is that process of taking the huge resource that is committed to health and social care and reshaping care delivery in order to respond to the changing needs of patients and, of course, the changing opportunities created for us, both by changing clinical practice and by changing technologies of a non-clinical nature. I noticed as I walked in, one of the sponsors of this conference is BT, and indeed several of the sponsors are involved in informatics. I think you had a talk about informatics yesterday. One of the drivers of change in the health and care system, as it is in every other form of economic activity, is the opportunity created by more efficient use of information across traditional boundaries. And that's just one example of the opportunities that exist to change the way care is delivered in order to meet the combination of economic and quality challenges that I've described. So there's a guy at the back who's held up a card and said that I'm halfway through my slot, and what I want to do is to set the challenge before you, to offer some hope that I do not believe this is a set of unmanageable challenges. I do believe that it's possible to bring these pieces together and to chart a way forward. I want to offer a summary of the way forward and then to allow remaining time for questions. I've hinted, I think, at what I think is the key to the way forward. If we focus on the needs of today's patients rather than yesterday's patients, if we focus on their desire and our desire on their behalf to intervene early, to allow them to lead as normal and healthy a life as possible, to avoid the unnecessary acute case, all of that argues in favour of more integrated community-based services, challenging the distinctions which have existed since 1948 for purely historical reasons between, for example, community health, primary health, and social care. Use the powers that existed in the old legislation and have been carried forward into the new legislation to reshape services that look across those traditional frontiers in order to better meet the needs of that group of patients. It is that process of change in the way care is delivered, which in my view should be at the heart of the debate about healthcare delivery. I hope that having put the bill on the statute book, had all the political arguments that we're all familiar with. If we didn't know the arguments, we should have learnt them over the last 22 years. We should now be able to put that back in the history books, use the power of commissioning to reshape the way care is delivered. And the people who hold the monkey of driving change into this system are the people who are responsible for the use of public money in order to deliver the combination of high quality and efficient services. And the key responsibility for delivering that rests with the commissioning system, with the commissioning board at its apex. And it's the responsibility for driving that change, how it's to be delivered, what the consequences are of delivering that change in the care model, that I think, frankly, should have been at the heart of the health debate over the last 2 years, but we can't relive those. Starting from where we are, it's 2 years more urgent to start talking about how commissioning is used to drive necessary change into the way care is delivered along the lines I've described.